All right, let's get right into it. Today, we're doing something a little different. We are putting you right in the hot seat. Think of this as a dry run for a high-stakes consultant surgery oral exam. You're the candidate, I'm your examiner. We're going to walk through a complex case of a malignant liver lesion, and trust me, there will be some twists. Let's see how you do.
Okay, take a deep breath. This is it. I'm your examiner, and I'm looking for a consultant-level performance. That means you need to be clear, you need to be structured, and above all, you need to be safe. So let's not waste any time. Let's begin.
Here's the case. You've got a 65-year-old man. Known history of hepatitis C. A screening ultrasound picks up a 4-centimeter lesion in his liver. Tell me how you're going to approach this. Go.
Thank you. My approach, of course, is going to be systematic. I'd start with a focused history and a physical examination. From there, I'll build a differential diagnosis and then order the right investigations to really nail down the diagnosis and stage the disease properly.
Okay, so given this patient's history of hepatitis C, which is a major risk factor for cirrhosis, the number one thing on my list, my top differential, has to be hepatocellular carcinoma, or HCC. But you can't get tunnel vision. I'd also keep intrahepatic cholangiocarcinoma in mind, as well as metastatic disease, most often from a colorectal cancer.
So, to sort these out, I'm going to need a few key tests. Imaging is crucial. I'd order a triple-phase CT or an MRI, and what I'm looking for is that classic sign of HCC, bright enhancement in the arterial phase followed by a washout in the venous phase. At the same time, I'd get some blood work, specifically serum tumor markers. I'm talking alpha-fetoprotein for HCC, but also CEA and CA1999, just in case it's one of the other possibilities.
Correct. Your imaging comes back, and it's textbook for HCC. You see that arterial enhancement and the washout. You don't need a biopsy. The diagnosis is confirmed. What's next? Move it along.
Okay, with HCC confirmed, my thinking immediately splits into two parallel tracks. First, I have to assess his underlying liver function. That's going to tell me if he can even tolerate surgery. Second, I need to stage the cancer itself to figure out if it's actually resectable.
For a patient with a cirrhotic liver, their functional reserve is everything. So the first tool I'm reaching for is the Child-Pugh score. It looks at 5 key things: albumin, bilirubin, INR, ascites, and encephalopathy. This will give me a score that classifies him as class A, B, or C. And that classification is absolutely critical for deciding what we can and can't do for him.
His labs come back. You do the calculation. He's a Child-Pugh class A, and let's say he has no signs of portal hypertension. So he's a potential candidate for surgery. Give me the non-negotiable criteria for resection.
The criteria for resection are incredibly strict, and for good reason. First, the patient has to be Child-Pugh A without portal hypertension, which he is. Then, from a technical standpoint, I need to be sure I can get a 1 centimeter negative margin, leave behind an adequate future liver remnant, that's key, and I have to preserve the plumbing, the blood inflow, the blood outflow, and the biliary drainage.
Okay, good. Now let's change things up. What if he was Child-Pugh B? He's no longer a candidate for resection. What's the gold standard treatment for him now?
Right. For a Child-Pugh B patient, resection is off the table. The gold standard becomes a full liver transplantation. Now, not everyone is eligible. We use specific criteria, most famously the Malignant criteria. That's a single tumor up to 5 centimeters or up to 3 tumors, none larger than 3 centimeters. The UCSF criteria are a little more expansive. Our patient with his single 4-centimeter lesion would actually fit both.
So he's a transplant candidate. But you know as well as I do, he's not getting a new liver tomorrow. He's on a waiting list. What's your plan to manage his cancer while he waits? What are your options?
While he's on that transplant waiting list, we absolutely have to control the tumor. We call this bridging therapy. The whole point is to keep him from progressing outside of the transplant criteria. For his 4-centimeter lesion, the best option is something called transarterial chemoembolization, or TACE. Now, if his lesion were smaller, say under 3 centimeters, we'd probably be looking at thermal ablation instead.
Stop. Forget the plan. You get a frantic call from the nurse on the ward. Your patient is vomiting massive amounts of bright red blood. He's having a huge hematemesis. The team is panicking. This is a life-threatening emergency. What do you do right now?
Okay, my first thought is this has to be a variceal bleed. It's a classic and deadly complication of his underlying cirrhosis and portal hypertension. I have to act immediately and decisively.
So talk me through it. Don't just list things. What are your immediate actions, step by step? People are looking at you. A life is on the line. Go.
Okay, first things first. This is an ABC problem.
Airway. Is it protected? Do I need to intubate? Breathing? Get him on high-flow oxygen. Circulation? I need 2 large-bore IVs in him right now. I'm calling for help. I need ICU and gastroenterology stat. And we're starting resuscitation, but carefully. My hemoglobin target is actually quite low, around 7 to 8, because over-resuscitating will just pump up his portal pressure and make the bleeding worse.
At the exact same time as we're resuscitating, I'm ordering medications. He needs broad-spectrum antibiotics like ceftriaxone, he needs octreotide to reduce splanchnic blood flow, and a proton pump inhibitor. But the definitive move is to get him to endoscopy for an urgent EGD, where we can perform band ligation on the bleeding varices. If that fails, or if he rebleeds, the next step is a TIPS procedure.
Okay, you stabilized him, you managed the crisis. We could go back to his cancer plan, but let's pause. The viva is over. Let's just take a moment and break down what we just went through, and more importantly, what it takes to actually pass a station like this when the pressure is on.
Look, what we saw today wasn't just about memorizing facts. Anyone can do that. It was about showing a safe, logical, and systematic approach. It's about fundamentally understanding the patient's physiology, knowing why you check a child PUC score. It's about knowing the hard and fast criteria for major operations. And maybe most importantly, it's about being the calm center of the storm and following protocol when an emergency hits. That's what they're looking for.
So you've seen the case, you've talked through the plan, you even handled a major crisis. But the real question isn't about this one scenario. It's about whether you're ready to be the one making these life or death decisions, day in and day out. Are you really ready to be the consultant? Something to think about. Thanks for joining us.